Okay, good evening, everybody. Welcome. I think we will have quite a wide audience from around the world, and it's a pleasure to welcome to this webinar three great colleagues who I've seen in this field over many years, particularly in the Chiari and Syringomyelia meetings and that we've held internationally. And it's a pleasure to welcome them. And I will introduce Andy Broadbelt, who's an esteemed colleague and a fantastic neurosurgeon from Liverpool Walton Centre of Excellence, who's got enormous experience in this field and will set the scene with the first part of the talk. Also, we have three continents represented in two hemispheres, and second would be Professor Marcus Studley from Sydney in Australia, who is one of our excellent speakers and a good friend and colleague who's well versed in this field and the nuances and the great truths and the controversies. Marcus will talk to us more about the image findings and why we should operate and when to operate and what the aims are and some of the unknowns that we should cover in this great talk. And last but not least is Paolo, Professor Paolo Bolognesi from New York. Welcome, Paolo. Paolo, well, none of the guests need introduction. Paolo's from the famous Chiari Center in New York, and I know there's several there now, but he's from the first and from his work with Professor Milrat. And Paolo has done over 1,500 of the surgeries and is well versed in this field and an international well-known expert. So thank you very much, team, for joining. Welcome to everybody. I know these are testing times with the current COVID crisis, which is a test for all individuals, communities, families, nations, internationally. We've got some of us have the winter blues and our own vicissitudes of life with tests and trials. But it's such a pleasure to be together, learn together, and I would invite some of the great experts and everyone who's joining in to really allow us to benefit from their knowledge and their wisdom, and also ask any questions that they wish or make any comments. Could I invite them to please do that in the Q&A section, so that I can see that and perhaps put the question in a timely fashion to our guests. And at the end of the presentation, we are going to have an open platform with Q&A. So wonderful. Let us begin. Andrew, please, would you like to start with your talk? Thank you.
Right, good evening, everybody. It's been a real pleasure to be invited to chat. I'd like you to think of this as the starter before the main event coming up later. So what I want to do is sort of set the stage for how I think about Chiari and how I think about the initial assessment and investigation of people who present with a Chiari. So I think when we think about dealing with patients with a Chiari, it's more than just taking away a bit of bone. The patient on the left here presented with symptoms you can attribute to their syrinx. The patient on the right had multiple surgeries before they were referred to me and multiple cervical shunts placed. I'd like to contend that in both these cases, re-exploration of the posterior fossa or a decompression is the wrong thing to do. And we'll come back to them later on in the talk. So the aim of what I'd like to do first is just to give a bit of an overview, try and get a definition together, and talk a little bit about how I see assessment and investigation of people with a Chiari and how I think of going through that. This is a screenshot of the English translation of Chiari's original paper, where he described 3 types of cerebellar herniation. And his type 1 is characterized, as you see by what he said here, by elongation of the tonsils down into the spinal canal. Types 2 and 3 are different than type 1. Types 2 and 3 are dysraphic conditions, usually associated with spina bifida and hydrocephalus. Type 2 is where the cerebellar tonsils and the fourth ventricle descend into the spinal canal. Type 3 is an occipital myelomeningocele with cerebellar contents. So we need to just think about the definition a little bit. And traditionally, we define a Chiari malformation as tonsillar descent more than or equal to 5 millimeters below the foramen magnum. And this came from a paper by Barkovich in 1986, where they looked at 200 patients, what they called normal patients on MR, and another 20 people with symptoms of a Chiari. And what they suggested was that you actually see up to 5 millimeters tonsillar descent in normal people, but you can, sorry, is there somebody on the line? No?
No, Andy, you're doing fine. Please continue.
So you can see up to 5 millimeters in normal people. They actually started with a definition of 2 millimeters being abnormal, and this has since changed to 5 millimeters. Other types of Chiari have been described. So a Chiari naught has been described, where there is no tonsillar descent and you get an associated syrinx. So a Chiari 0.5, which is 3 to 5 millimeters of tonsillar descent. A Chiari 1.5, which is said to be tonsillar descent with descent of the medulla oblongata. But I would contend that this definition is now outdated. And what we need to think about is that maybe it's better to think about this as it's a symptom complex which is caused by a variety of conditions that lead to either a disorder of CSF dynamics or compression at the craniocervical junction. Now, although that's a bit of a mouthful, that's giving you maybe a better idea of what the underlying problem is. And that's part of the problem, is understanding what the problem is, what it is we are treating. And I know Marcus will talk about this a little bit more in his talk. If we leave that as our definition of a Chiari, then a complex Chiari is that plus something else, be it basilar invagination, be it a syrinx, be it hypermobility at the craniocervical junction. And then I'd like to define a syrinx as any fluid-filled cavity, as I've defined here, also excluding those prominent central canals that you see on modern imaging. So 1% of the adult population is thought to have a Chiari, and it's more common in children. And as you get older, the amount of tonsillar descent you have reduces. But only 1% of this population are symptomatic. And this to me is the problem with the current definition. If such a large percentage of the population have it, but only a tiny proportion need treatment, maybe we need to think about what it is we are treating in more detail. Up to half of patients who have a symptomatic Chiari will develop a syrinx. So the way I think about when I'm speaking to a patient or seeing a patient and thinking about investigations, the first thing I want to do is try and understand what's the cause of the Chiari. This is a paper by Millerat back in 2010, and in it he looked at the volume of the posterior fossa. And what they found was that in 2/3 of patients, what he described as the classical Chiari 1 or the Chiari 2, they had posterior fossa volumes of 165 mils. And these were reduced, much reduced from the normal value of about 190. But a significant group had a normal posterior fossa volume. And this really gives you the principle of how I think about Chiari, the causes of Chiari. In the majority of patients, it's due to a small posterior fossa, but in a sizable minority, it can be something else. And this minority can be divided into things from above, things at the craniocervical junction, and things from below. So things from above are things like hydrocephalus, tumors, idiopathic intracranial hypertension. Things at the level of the craniocervical junction are things like basilar invagination, when you have instability there. And things below are tethered cords, occult CSF leaks, that sort of thing. So what it starts when you start talking to a patient and goes on from your examination, it's thinking about what the underlying cause is. So the first step is obviously talking to a patient. And as all of us know, when we deal with a Chiari patient, they can come with 3, 4, or 5 pages of text of their symptoms. For me, what's important is to headline what are the most relevant things to them? What are their worst symptoms that affect them the most? And try and give them their top one, top three. And that's what I'm aiming to see if I can help and treat. The next step is a complete neurological examination. And I think nowadays we have to include an assessment of hypermobility, because that does seem to make a difference. And I'll talk about that a little bit later as part of the assessment. So what investigations? If 1% of the population has a Chiari and more people are having scans, what level of investigation do we need to do for these people? For me, I think that if you have an asymptomatic Chiari, then an imaging of your brain and cervical spine should be enough. If you have any symptoms, you have a symptomatic Chiari or any evidence of a syrinx or abnormality, then you really need to image the whole of the spine. So a whole neuroaxis imaging. People use flow studies, and certainly there's a suggestion in the literature that if you have obstruction of CSF flow at the craniocervical junction, that you will do better if you decompress them and restore flow. And there's many other studies. I'm not going to talk about cine-MR because I think Marcus is going to do that. I will mention about upright imaging though. So there's more and more upright imaging done, and it hasn't really been proven. It does appear that it's obviously easier to do flexion extension views in an upright scanner, and the flexion views do appear to be useful for looking at hypermobility at the craniocervical junction. So going to just talk a bit about the associated conditions in a little bit more detail. So again, if we think about things from above, about 10% of patients with a Chiari will have hydrocephalus, and 3% will have idiopathic intracranial hypertension. If we're treating these with a posterior fossa decompression, we're likely to have worsening problems, CSF leaks, and it's not the treatment of choice. And it may be, if you're thinking about this when you're talking to somebody or examining them, that you consider intracranial pressure monitoring or further investigations, venography or other things to look in more detail and try and work out what the underlying cause is here. So I mentioned it before about ehlers-Danlos loss, and this has been a real controversial issue, and I'm sure Paolo will talk about this a little bit later. So in 2007, Miller published a paper, a large series of patients, in which he found that a significant minority had ehlers-Danlos loss and a degree of hypermobility at the craniocervical junction. And he suggested this was related to their symptoms, and you needed to take this into account when you're treating patients. And if we're looking at how we assess people with that, they have basically used two main angles. So on a flexion MR, they use the Grab-Oakes and clivo-axial angle. So Grab-Oakes just describes if you draw a line from the back of the clivus to the posterior inferior border of C2, and you do a perpendicular line, this distance needs to be 9 millimeters or less to be more normal, or more than 9 millimeters to be abnormal. For the clivo-axial angle, if you draw a line at the posterior aspect of the clivus and then down the posterior borders of the cervical spine, if this angle is less than 135 degrees, there's a suggestion that this is hypermobile. These are not completely accepted numbers, and it's not completely clear where is hypermobility related to instability and what falls in between. There have been two papers of series published in these group of patients. The first one back in only last year by Fraser Henderson, of only 22 patients, but he showed significant improvement in the cohort that he had looked at. Now, other groups have suggested that, in fact, the cause of all Chiari problems is instability, and it's C1-C2 instability that is the problem that causes all the symptoms. What's interesting is that initial paper, 70% of these patients had basilar invagination. And that's not the population that I see in my practice or that you see when you look in the literature. So there may be a degree of instability, and it's certainly something to take into account when you're assessing patients and looking at maybe more dynamic imaging, but I don't think it's there in everybody. So basilar invagination, we do see basilar invagination in these patients. And just to remind everybody, basilar invagination can be defined as protrusion of the dens above McRae's line, which is just basically a line across the foramen magnum, or 5 millimeters above Chamberlain's line, which is a line from the posterior end of the hard palate to the posterior edge of the foramen magnum. Jörg Kleekamp did a very good review of his results of comparing his patients who he treated with those who had basilar invagination. And this is a photo from one of his, from his paper. And he had good results, but it required more treatment. Sometimes it required removal of the odontoid peg, sometimes it required fixation. What was interesting is in the group of patients who failed his treatment initially, most of them seemed to fail either because of hardware failure or because he hadn't fixed them in the first place. So it just suggested maybe you needed to do a bit more aggressive fixation in this group of patients. But I'm sure my esteemed colleagues will be able to comment and disagree with me a bit later. So this was the patient we saw at the beginning who'd had these multiple operations. Now she came back with worsening neck pain, worsening neurological deficit. She was actually pretty mobile and able to use everything, which I'm always surprised by looking at this scan. And it was clear that she had a degree of instability. Going back in, we felt was high risk. And so one of my very esteemed, clever, complex spinal colleagues fixed her, and that made her a lot better. Pain resolved and her neurology improved, and she went home. Now, she may need further fixation in the back. She may need something doing her up at some point in the future, but at the moment that stabilized her. And I think for her, that was the right thing at that time. And finally from below, and I've put this photo in for Professor Studley so he feels right at home, because obviously the main information we get in the UK about Australia is how many shark attacks there have been. And now there aren't any UK tourists there. They seem to be going for the Australians in a big way. I understand there's been 8 deaths in the last year of shark attacks in Australia, which is pretty dreadful. So from below, the thing that, again, another paper from Millarat talked about tethered cord, and there's been a lot in the literature about tethered cord. In Millarat's view, in Millarat's study, 15% of his cohort had tethered cord, and a large proportion were untethered. And he showed that people improved, their symptoms improved, and there were other measurements that suggested that the brainstem length reduced, the conus and the tonsils all went up, and patients were a lot better, and there was a low complication rate. But the difficulty I had with that paper, and I've always had, is the patients weren't tethered by the standard definition. If we look at, this is a picture of all their results and what symptoms they had and what signs they had. And if we just focus in on the adult group, their conus medullaris, 98% were actually above the lower end plate of L2. So he was using a definition that it might just be a symptom that fitted with tethered cord. It might just be a slightly thickened phylum. And so I think it's much more difficult to say that every patient who has a Chiari needs to be untethered. I'm absolutely not saying that. But I think it is worth, sorry, let's just go back. I think it is worth remembering that if you do have a tethered cord, you need to look at it, you need to have found it. And it may be that if you've got a tethered cord, you need to have some urological investigations, some neurodynamics. We saw this patient at the beginning of the talk, and he had his rest of spine MR, and that showed this massive frontal meningocele. Now, this is obviously pretty unusual, but it makes the point that if you've got a Chiari, and especially the Chiaris that get worse over time, you've got to think about something from below pulling it down. And that might be an occult CSF leak, that might patients who have LP shunts, or even tethered cord. But you need to look for it to find it. So I'm not spending a lot of time on syringomyelia. I'm just going to talk for this slide about syringomyelia. And syringomyelia always comes from something else. If you've got a Chiari, the most likely cause of the syrinx is from the Chiari. And so you treat the underlying cause. So if it's a Chiari, you look for the underlying cause of the Chiari and you treat that if it needs treatment. If you look at children with idiopathic scoliosis, 1 in 7 on MR imaging have an underlying neurological issue. 30% of children with a Chiari and a syrinx will get a degree of scoliosis. There was a good review by Wang et al. Back in 2012 who showed that of patients who had a Chiari and a syrinx and a scoliosis, 50% of them either improved or it stabilized their curve if you treated the Chiari. So finally, the take-home points from my talk, my prequel to the main event, is firstly, I don't think the 5mm definition is good enough any longer. And I think we have to think about a better way of defining what it is we're talking about. In the assessment of a patient with a Chiari, I always feel when you're thinking about it clinically, radiologically, you need to look for the underlying problem. If it is a small posterior fossa, that's fine. You can get on and treat that, but think about other things. And finally, when you're investigating patients, if they're asymptomatic, an MR brain and cervical spine should be enough. If they've got any symptoms or a syrinx, you need to really consider imaging the whole spine, and you may need to do further investigations, some of which I've spoken about this evening. Right, that's it. I think questions are at the end, but Mansour will let us know. Thank you very much.
Andrew, that was excellent, very clear, concise, absolutely to the point, and it sets the scene beautifully. May I just take this opportunity, because there's hundreds of people online watching and enjoying this, and there's a few questions, but if I could just ask you very briefly, if you don't mind trying to answer a few. Pablo is asking, in which cases do you need, I think what he's referring to is ICP monitoring before doing considering a suboccipital craniectomy? You've already touched on that, but if you could make a few comments.
So I think it's just being cognizant that these patients can have raised intracranial pressure, and it's a lot from the history, isn't it? It's from the history, you know, some people would have papilledema, but most of it's from the history. And you're talking to patients and you get a feel that it's a hydrocephalus problem from the standard sort of story you get from hydrocephalus with an additional problem of Chiari. So it's just having it in the back of your mind when you're talking to these people and exploring that as you discuss this with them. You may see things on the imaging, you may see an empty cellar, you may see other signs that just, you know, plump ventricles or other things that just make you a little bit suspicious. But for me, it's a lot in the history.
Thank you, Andrew. Another quick question is, you've clearly stated, and it's very obvious and beautifully said, and that we're not dealing with one condition. It's a manifestation of things, and there are associated findings as well. And it can't be one size or one treatment fits all. But regarding the massive number of incidental Chiaris that we see, referred by radiologists, as you've alluded to, 1% of the population have that. Could you make any comments about what you would like radiologists to report more on in terms of the findings, so that it would become more clear who to investigate based on the radiological findings? Is there anything regarding the tonsils or the CSF, anything you would like to highlight?
Well, I think what I'd do, Mansour, is I'd throw that back to the community and say, look, the definition up till now is a 5mm tonsillar descent. So it's absolutely fine for the radiologist to report that. They're not seeing the patients. They're not seeing, they can only report what they see on the imaging. For me, if you've got the right definition for what it is you want, what you think is abnormal, then that helps everybody. So if you say you're looking for CSF flow or compression at the craniocervical junction, and they don't see that, then, and that's part of your definition, then to me that helps with determining who you should see. I'm very reluctant to say, well, it's the number of millimeters or it's the shape of the tonsils, because, you know, often when you look at the studies that look at those sorts of things, they're relatively small numbers of patients. Yeah. And to me, still the most important thing is what symptoms the patient has. It's your clinical assessment of the patient.
Thank you, Andrew. Andrew, there's a lot of people who are very concerned about the patient of yours with the anterior meningocele, and they're really keen to know what happened to this patient and how you managed. I've got to ask this question because a lot of people are posting that. So if you could make a short comment what happened, I would be grateful.
So he's actually a patient of one of my colleagues who deals a lot more with the dystrophic conditions than I do, and he's having his anterior meningocele repaired. I can't give you any more details than that, I'm afraid.
No, that's fine. I think that's brilliant, Andrew. There's a lot more other questions, particularly people asking about bony decompression only and so on, which I think we're going to cover in later on today and next webinar. Perhaps what we can do is crack on with the next excellent speaker. Marcus, can I invite you to please start your talk and tell us more about Chiari-1 malformation? Thank you.
Sure, thanks. And thanks, Samantha, for asking me to contribute today. It's a real pleasure. So I'm going to go through some imaging studies. Obviously, in the time available, I can't go through a lot of details, and I'll touch on surgical indications. We're going to save technique details for another session, but I will mention a little bit about those and talk about outcomes and then some special considerations. So for imaging studies, I'll go through these techniques and where I think they're useful. So obviously, MRI is the mainstay of imaging these patients. And I'm not going to talk a lot about syringomyelia, but I just wanted to make the point here that MR imaging of the syrinx is very important. And so this syrinx at the top is really an expanded central canal and has no damage to the cord, whereas this syrinx has ruptured through the central canal and there is damage to the cord in this region, and that correlates with the patient's symptoms. But there are obviously many different features that you can see on MR, and so severe Chiari malformation, skull base abnormality, associated syrinx. But there are nuances, and so this might appear to be a small syrinx, but it's actually communicating with the fourth ventricle. You can see the central canal communicating here to the fourth ventricle, and so this is a special type of syrinx where there is obstruction of CSF outflow from the fourth ventricle, probably associated with that Chiari malformation, but it's different to the common type of syrinx associated with Chiari. And this case is another example where one might think it's not a particularly severe Chiari malformation, and the underlying pathology here may in fact be membranous obstruction of the CSF outflow of the fourth ventricle, causing this communicating syrinx. And then there are these cases that I think points to what Andy was talking about, where technically this would not meet the criterion for Chiari malformation being 5 millimeters below the foramen magnum. And yet I think most of us would probably think this is the cause of the associated syrinx. Andy mentioned CSF flow studies, and in general, I don't find these especially useful for the majority of Chiari patients. And I've put in this particular patient who has had a posterior fossa decompression for Chiari malformation and remains symptomatic. And this is the kind of case where this technique can be useful. So if we look at just the plain T2 sagittal image, it may appear that there is a CSF space dorsal to the cerebellum, but on the gradient, on the phase contrast cine studies, it's evident that there is no CSF flow dorsal to the cerebellum. And so one might think that that is because there is ongoing constriction. The problem, of course, is that you don't really know whether that is compression causing constriction or whether it's just scarring. Scarring can manifest, the gliosis of the cerebellum attaching to a membrane, attaching to the dura can look just like that on T2, so it's not necessarily CSF. So we find it useful to use the cardiac-gated BFFE or Fiesta studies to answer that question. So for that patient who's had the posterior fossa decompression, it's evident that the cerebellum remains mobile, and so that is not an adherence problem, that is an ongoing constriction problem, so that the obstruction of CSF flow in this case is caused by ongoing constriction here. Whereas this case on the right, with a communicating syrinx, it's evident that the cerebellum is completely adherent to the overlying patch graft. And so these two patients, although they present clinically with very similar findings, have very different underlying pathology. We do a lot of imaging of cerebellar motion. So in the non-operated Chiari malformation patients, we find this useful in helping to determine the severity of the malformation. It's very good at demonstrating the associated malformation of the upper cord or lower medulla. But it also demonstrates that for these patients, the cerebellum doesn't just move up and down as a single piece, it actually stretches, so that the motion of the inferior part of the cerebellum is much greater than the motion of the superior part of the cerebellum. And I'll talk about that in a minute. We use CT for assessing skull base abnormalities, and much more so than using upright MRI or flexion extension MRI. So we find that's the best technique for showing skull base. Looking at, this is a patient who's had an operation elsewhere and has ongoing symptoms, and so assessing the degree of bony removal and showing abnormalities such as the simulation of the atlas here. I mentioned vascular imaging because I've often wondered whether we should do routine vascular imaging, and many of you may do that. It would be useful, I suppose, to know the exact relationship of the vertebral arteries to C1 prior to surgery. But in particular, it's the venous anatomy that can be problematic. So I've personally had a couple of cases where at operation found that a major venous dural sinus is running right down the middle of the posterior fossa, as in this published case. And clearly division of that sinus would be a very high risk. So I haven't included routine imaging of these vascular structures, but there would be a case to be made for that. I'm going to touch just on some of the dynamic imaging, by that I mean looking for hypermobility and skull base abnormalities, but I know Paolo is going to talk a bit about that. And Andy also mentioned these measurements. But the way I think of it is there's the classical problem of skull base invagination where there is compression of the brainstem. I think we're all very comfortable with the concept that patients present with brainstem abnormalities caused by compression from these abnormal skull base arrangements. The more recent concept, though, is the cervicomedullary syndrome, where it's not necessarily compression of the brainstem that is causing the clinical problems, but stretching of the brainstem that occurs with patients who are very mobile. So an example here where a patient in the difference between flexion and extension has a change in the clival axis angle, a change in the distance between the clivus and the dens. And the concept there is that that excess movement may stretch the brainstem and cause neurological deficits. So just moving on to the surgical indications, I've listed them here as, I think we would all be very comfortable with the idea that patients presenting with Chiari malformation with clinical signs and symptoms of brainstem dysfunction, a decompression is appropriate. I don't think there's any dispute about that, other than to say that C1 and C2 fusion might be another way to treat those patients. For a patient with enlarging or symptomatic syrinx, an example here is a young girl. I've had to put two slices in to show the severe Chiari malformation and no syrinx, beginning of last year, and then a recent preoperative scan showing the development of the syrinx in the cervical cord and thoracic cord. So I think that, again, we would all be comfortable with the concept that for a patient with a syrinx that's certainly symptomatic or enlarging, that treatment of the Chiari malformation is entirely appropriate. But then it comes to the less obvious things, and so if we talk about headache, it's the cough-induced headache that is as we all know, the typical feature of Chiari malformation. And the way I put it to patients is that I want to get to the point of thinking, is the headache that you're complaining of related to the Chiari malformation? Because often it's not. They might have migraine or other types of headache, but if it's the very typical cough-induced occipital headache, it then becomes a question of whether that is sufficiently problematic for them to justify surgery. And I try to do it by putting to my patients that if the concept or the idea for them of coming into hospital, having the back of the head open, spending a night in ICU, 5 days in hospital, a few weeks recovering, if that doesn't sound too bad in relationship to the headache, then maybe they've reached that threshold. But certainly just the presence of headache is not sufficient indication. And then perhaps even more controversially is the cognitive disturbance, and then I'll touch on the CSF disorders that Andy mentioned. So it's becoming increasingly clear that patients don't just complain of brain fog, they do have cognitive dysfunction. And there's some evidence that there are structural reasons why that might be the case. And it might be, for example, that stretching or movement of the cerebellum is disturbing pathways from the cerebellum to the supratentorial structures, and that is the underlying structural mechanism for the so-called brain fog or the cognitive disturbance, with clearly demonstrated abnormalities of memory and retention that is that persists even if you control for the pain level. So it's not just that these patients are in chronic pain that causes their cognitive dysfunction. There seems to be a real structural underlying mechanism here. The question, of course, is whether treating the Chiari malformation will resolve that. That will certainly open the floodgates if it's demonstrated that treating Chiari malformation reverses the cognitive deficit. And I think that will hinge on getting a better understanding of what is the actual underlying structural disturbance. I think, judging from what Andy just said, I think my approach here might be slightly different. So this is the same patient. Again, I've had to put in a couple of slices to show the Chiari malformation and the empty cella. There was also CSF around the optic nerves. So this is a patient presenting with BIH or IIH. Now, my approach here is that if the symptoms are much more in keeping with the Chiari malformation, then I'll treat the Chiari malformation first. If the symptoms are much more suggestive that the intracranial pressure is the problem, then that's where I would measure the intracranial pressure first and consider treating that first. But I'd have to say that the majority of patients that I see seem to be more symptomatic from the Chiari malformation. And I put it to them that we treat that first and then consider the intracranial hypertension on its merits. And I've had 2 or 3 patients where we've ended up shunting them after decompressing the Chiari malformation. Similarly, though, for hydrocephalus, unless hydrocephalus seems to be the primary problem, I will generally treat the Chiari malformation first, because in a reasonable number of these patients, it's actually a fourth ventricle outflow obstruction that is the underlying pathology, and that can be addressed with posterior fossa decompression. So if I just now turn to the surgical techniques available, and we're not going to go into any details here, but the most commonly used technique is posterior fossa decompression. There are an enormous variety of techniques, and I don't propose to go into those today. But I wanted to mention the 2 other perhaps potentially paradigm shifting possibilities. The MIST, and Paolo, I've taken this from your paper, I hope you don't mind, the minimally invasive subpial tonsillar resection. And Paolo, you'll know that the extent of bony resection here indicated in this diagram is probably more than what Yong-Liu does, which is really a very minimal bony resection, a small linear opening of the dura, then resecting the tonsils, and then sewing up the arachnoid separately, and then sewing up the dura. And it made me realize that this is perhaps not a technique that's addressing compression so much, is it may be addressing the cerebellum as the real underlying problem rather than compression. And I'm going to touch on that in a minute. And the third potentially paradigm shifting approach is the C1-C2 fusion proposed by Atul Goel that Andy mentioned. I agree with Andy. I think the population that Atul reports is very different to the population that I see, and that I think most people in European countries see, which is whether the skull base abnormalities are the minority rather than the majority. And although Atul publishes really terrific results in his papers from doing C1-2 fusion, I'm not yet convinced that is the appropriate operation for all patients. So that really, I think, makes me think about these 2 questions in terms of when we're operating. What actually are we trying to address? And then, what are the complications we're trying to avoid? And I think if we could focus more on those questions rather than on, is my technique better than your technique, I think this is where we might get some advancement. And I think what we're trying to address with any operation for Chiari malformation is, first of all, to address any brainstem dysfunction, but then most commonly we're trying to address the headache, resolve the syrinx, and possibly to address the cognitive dysfunction. And the real complications we want to avoid is CSF leak and associated meningitis, and cerebellar slump, and cerebellar tethering and scarring, similar to the case I showed earlier. So I think that for brainstem dysfunction related to compression, then a posterior fossa decompression is a pretty reasonable way to start, and I don't see any major controversies there, other than to say that this patient on the right who has had a posterior fossa decompression for symptomatic Chiari malformation, has what would be considered, I think, a very severe skull base abnormality, but is actually completely asymptomatic. And so the mere presence of these abnormal angles and the presence of imaging evidence of brainstem compression does not necessarily mean that needs to be addressed. The big question, of course, is the headache, and I think the real problem here is that we don't actually understand what it is that causes headache in Chiari malformation patients. When we're doing surgery, are we actually trying to decompress? Are we trying to allow CSF to move? Or is it the compression of the brainstem that's causing the headache? Or is it pressure changes in the whole cranium related to abnormalities of CSF flow? Or is it something else? And a possibility that we've touched on in some of our research is this concept that cerebellar stretch might in some way be responsible for headache. So in Chiari patients, the superior part of the cerebellum doesn't move much. The cerebellar tonsils move, so the cerebellum is stretching. And so the concept here is that that may be generating signals from pathways from the cerebellum to supratentorial structures, or it may be causing stimulation of perivascular nerve fibers. But in any case, it's clear that posterior fossa decompression results in resolution of that stretching phenomenon and resolution of the headaches. And so if the stretch is the cause of the headache rather than the compression or the CSF flow, then addressing the stretch is what we're trying to do with surgery. And that may be what it is that the MIST or the subpial resection is actually achieving rather than decompression. And so I'd really like to encourage everyone to start thinking more about that question than what technique we should be using. There is some evidence pointing to whether we should do duroplasties or not, or just bone only. And in some of these graphs, there are comparisons here from this publication of posterior fossa decompression without duroplasty and then with duroplasty. Not much difference with regard to headache. If we're trying to fix the syrinx, again, I think it's fair to say that we don't really know what we're trying to fix. We'll often say that we're trying to re-establish CSF flow, but it may be that we're actually re-establishing the transmission of pulsations, or to re-establish the synchrony of pulsations in the spine and the head. I think that's very poorly understood at the moment. Again, comparing posterior fossa decompression with duroplasty without duroplasty, the way this graph is orientated is demonstrating that there's actually a benefit with duroplasty with regard to syrinx resolution. And then with cognitive dysfunction, again, if we can understand the structural basis for cognitive dysfunction, then perhaps we can start thinking about how it is we're actually addressing it. And it may be, for example, that cerebellar stretch is the cause of the cognitive dysfunction. It could be that it is affecting those cerebellar to supratentorial pathways, and that the subtonsillar resection is addressing that stretch and potentially could be helpful. So again, it's a question of trying to work out what it is we're trying to fix. In terms of avoiding complications, I think it's fairly obvious that opening the dura would have a lower risk of meningitis. But I think what troubles me is that in many publications, there are rates of meningitis reported of 10% or even up to 18 or more % of patients develop meningitis after posterior fossa decompression. And in these publications, comparing different types of dural graft. And for me, what these publications are telling me is that none of these are good, because that is an extraordinarily high complication rate of meningitis from my perspective. And so that's telling me that these are not the right techniques to use. And the same with CSF leak. It's no surprise that not opening the dura has a lower risk of CSF leak. But again, publications comparing different brands or different types of dural graft report extraordinarily high rates of CSF leak. I mean, we would expect to see CSF leak rates around 1% or less. And here we're seeing rates reported of 20 or 30%, pseudomeningocele and CSF leak rates above 10%. And I would suggest that these are really unacceptable, and that for rates of that degree, the technique ought to be revised. We also want to avoid slump, and I think this is what occurs when there is excessive bony removal or excessive dural grafting. Tethering is a terrible problem that occurs, in my experience, particularly with artificial graft materials such as Duragen or collagen-containing materials that may be useful in other parts of neurosurgery, but in the posterior fossa cause this terrible scarring of the cerebellum that is very difficult to address. We want to avoid that tethering because it does, this is a communicating syrinx, so that there's scarring of the outlets of the fourth ventricle that causes that syrinx. So we put all those things together, and the different various types of surgery, and I've sort of put here just rough negatives and positives for different techniques. The ones that really come out, apart from C1-2 fusion, which I haven't put in here, that a post-suppository decompression with a pericranial graft or just a minimally invasive technique with tonsil resection seem to have the best overall results in terms of resolution of symptoms and avoidance of complications. But we'll talk more about those techniques in another webinar. So just turning now to measuring outcomes. And I think we've done not very well in this regard so far in the literature, and although there's some improvement in more recent publications, but it's reasonable, I think, to focus first of all on complications. And I showed you in those other papers, reporting complications is important and needs to be done, but it's not really the goal. I think the goal ought to be around not just the clinical outcome, but what is the technical success? And again, just re-emphasize that at the moment, I don't think we really have a good understanding or a good fix on what are the technical parameters that we're trying to address. Is it CSF space dorsal to the cerebellum? Is it brainstem compression? Is it cerebellar stretching? And until we know what it is that is causing the problem, we can't really address the technical success. And the correlate of that, of course, is being able to determine what is the technical reason for non-success in patients who remain symptomatic. I think that's something we really need to focus on. In terms of clinical outcome, headache's obviously a difficult thing to report on. I'm involved in a group at the moment that's setting up a multi-center study trying to look at outcomes related to surgery. And we've settled on the migraine inventory, which is summarized here as a way of trying to quantify the impact of headache on a person's life. Quality of life scores, I've always used as SF12, but there are many others, and I think so long as we're using something that gives some sort of validated semi-quantitative score, then that's going to improve our research and understanding of our outcomes. Cognitive function, that's really had a lot of focus recently. That's very difficult to assess because you need formal neuropsychology assessment to really measure this. Just finally, a few special considerations, and I know a lot of people will get asked frequently about how to manage their patients who are pregnant. Pregnancy itself and natural childbirth, I don't think there's any evidence of a concern. If you consider the physiological changes that occur, particularly during childbirth, yes, there may be elevations of intracranial pressure, but that is also associated with elevations of spinal pressure. I don't think there's any change in the gradient. And certainly in these two recent publications from this year, looking at the first publication, a review of the literature, and the second, a large series of over 800 patients, there are really no significant complications associated with pregnancy and delivery. And one of the comments from Cormac Ma's paper here is kind of downplaying it for me, saying that because people tend to change their practice when a patient has Chiari malformation and there are no problems, that maybe they shouldn't change their practice. And I'm not sure I agree with that, because I think there is a concern regarding particularly the possibility of lumbar puncture. And obviously that doesn't pertain just to pregnancy, but it's a real question when pregnant patients are about to give birth, and there's a question of can they have an epidural. I think if they have an epidural that doesn't puncture the dura, there's no concern because there's no change in pressures. But I'm certainly aware of a few cases in Australia that have been medico-legal cases, so we can't publish them, where a patient either has had a lumbar puncture and they've had a Chiari malformation and then died, or had Chiari malformation, been pregnant, had an epidural, inadvertent dural puncture, and become quadriplegic. And there are a couple of reports in the literature along those lines. The concern I have, of course, is that if you drain CS in this kind of patient, you drain CSF from the spine, there is now a pressure differential. And I think if it's not a severe Chiari malformation and there is still CSF space around at the foramen magnum, that pressure differential can be resolved by CSF moving from the head to the spine. But in a severe Chiari malformation, then CSF can't move, and so the cerebral contents have to move. Something has to move to equilibrate the pressures. And so in those severe Chiari malformation patients, I don't think there's any doubt that it can happen. Rare, admittedly, but it can happen. And this is a published case, not in pregnancy, but a person who had a lumbar puncture in the presence of Chiari malformation and had this infarction of the cord and the cerebellar tonsils. So that's my concern. And so my advice to patients in pregnancy is to avoid epidural anesthesia and to avoid lumbar punctures at any stage if they have that kind of severe Chiari malformation. And the question of sport, again, Cormac-Mara has published a lot on this, and I think the numbers are pretty good that in very large series looking at sporting activities in patients with Chiari malformation, there really has never been a reported case of significant neurological problems occurring suddenly from any sporting activity or any minor injury. So when patients ask me this, I tell them I have no restrictions. Other than if they have an associated syrinx, I will ask them to avoid activities that might involve Valsalva type maneuvers, because I think that can be associated with worsening the syrinx. But I'm not particularly concerned about worsening from the Chiari malformation itself. And finally, this question came up for me recently where a patient asked me, was it okay that she'd just been mountain climbing and got a bad headache and she had a severe Chiari malformation? Of course, with cerebral edema, with altitude sickness, there is, I think, a theoretical concern that a patient with Chiari malformation might be more prone to sudden death in that setting. This is my literature search yesterday. There are 0 publications mentioning Chiari malformation and mountaineering or altitude sickness. So I guess on conceptual grounds, I'd be telling patients to be cautious about that, but there's no evidence for any problems. So that's all I've gone through those things, and happy to take any questions. Thanks, Mansur.
Marcus, thank you. Again, a fantastic, well-presented, concise series of points in your presentation. There are many questions, and before I ask a couple of them, if you don't mind, I just wanted to reiterate for the listeners and audience that we are going to have another webinar on the surgical techniques and the variations, because that is a huge subject where, do you do a bony decompression and the dimensions, dural opening, do you stitch the arachnoid, open the arachnoid, shrink the tonsils, resect the tonsils, and the other procedures that you can do for hydrocephalus and so on. So please do bear with us, although you've touched on some important points. Marcus, a question's come up about, if you don't mind, could you just say what are the main symptoms that you would consider an operation for, particularly when it comes to brainstem symptoms? So someone hasn't got a syrinx, they haven't got they've got a good going Chiari with compression. What are the chief symptoms that persuade you to offer an operation, particularly when it comes to brainstem symptoms?
So first of all, the objective symptoms. So if there is diplopia with evidence of extraocular movement disorder, I think that's a pretty strong indication. Central sleep apnea. So many of these patients will have sleep apnea, and they should have sleep studies. And if they've got central sleep apnea, I think that's a pretty strong indication that there is imaging evidence of significant brainstem compression. And the less objective things such as balance disturbance, hearing changes, and so on, I think they come into the mix. But often for those patients, they will also have headache. And so when it comes to making decisions about surgery, I will generally tell the patients that this is all about the headache. The difficulty, of course, is when patients don't have headache and they've got some brainstem symptoms. That happens sometimes. And I guess, admittedly, I will then rely on the severity of the imaging findings. If they've got significant brainstem compression and those balance disturbance type features, then I will lean towards surgery.
Thank you very much. Another question is regarding pregnancy and trauma. The fear that is in many patients, perhaps from false information and media and social media, things like sudden death. I recall in one newspaper in the UK, it was written, "Doctors told me if I laugh, I could die," and so on and so forth. Now, we all laugh at these things, but surely, if maybe you could expand more on this, since the beginning of time, and particularly the last 150 years of recorded literature and modern and evolving medicine, there's not been sudden deaths in pregnancy in large number of Chiaris that people have incidentally, and also with trauma and sports. Do you think we are being too cautious? And when you've mentioned, for example, in pregnancy and regional anesthesia, if someone has got a non-symptomatic Chiari or a Chiari which is not radiologically significant, surely a natural childbirth and even epidural anesthesia would be satisfactory, would be okay?
Oh, absolutely. I think if there's CSF space around the foramen magnum, then that you can, and if there's an inadvertent dural puncture, then you can get equilibration of the pressures by CSF movement, and then that's perfectly safe. It's where I think the imaging demonstrates no CSF space, and if there's a pressure differential, then something's got to move, and if that's going to be the cerebellar tonsils, then they're in trouble. So the imaging features are important, but I agree with you. I mean, we need. I think it's important for us to reassure the vast majority of patients that they are not at those risks.
Thank you. One last thing about trauma, which you mentioned, which comes up again and again in questions and debates. I know of cases following major trauma with raised intracranial pressure, and someone is really neurologically deteriorated with a known Chiari. And other than bacterial meningitis and having a lumbar puncture, I'm not aware of any, and those are very, very few. Would you say engaging in full contact sports in someone who's got without any tonsillar impaction, with good CSF spaces, without a syrinx, that would be fine? And what about those who have got a bit of tonsillar impaction, perhaps, and maybe a bit more risk?
So, I mean, I think there are good reasons to not engage in significant contact sports without Chiari. So, but if someone's got a mild Chiari, I tell them I have no concern about them. The situation often arises for me where I have a family and the kid's got Chiari and the kid wants to play rugby. And the parents say, "Is it okay for me to play rugby?" And I say, "Well, I think it is." And the parents go, "Oh no, we were hoping you would say, stop playing rugby." So, but I think for most of them, there's no evidence to suggest that there's a problem.
Thank you. If I may ask, because of the number of questions related to this, regarding the investigations for routine venograms that you mentioned, possibly, looking at MRV. So does everyone get an investigation before surgery, for example, or who gets an investigation regarding MRV? And are you really worried about venous compression?
I'm not worried about it, and I don't do routine venous vascular imaging. But I just made the point that there are cases where you take, I've been in a situation where I've done a suboccipital bony decompression, and then clearly there's a major venous sinus right in the middle. And so it just made me think about whether I should be doing venous imaging. And I asked this question at the Birmingham conference 2 years ago. And nobody there at that conference does routine certainly venous imaging, although everyone acknowledged that there are a small number of cases who have that.
Yeah. Thank you. Jake's asking this question, Jake Timothy from Leeds, about specifically if anyone has experience of removing C1 lateral tubercle for focal compression of the jugular vein. Before anyone answers this, I know this comes up. In veterinary studies, Claire Rusbridge and has published about, and others, about Cavalier King Charles Spaniel dogs with Chiari and syringomyelia, and it's well documented that if you've got jugular stenosis in that anatomy, that is a significant contributing factor with known pathophysiology. But I just wondered if you think this is a significant issue before contemplating surgery, or something we should look for all the time for Chiari, symptomatic Chiari.
I mean, it comes up, doesn't it, for IIH patients, doesn't it?
Yeah.
And I can't answer your question other than to say that it's certainly come up with some of my patients, and some of them have gone down that path and had styloid resection other procedures to decompress the jugular vein. I've not been convinced that that's been successful in any patients. But it's an issue that, you know, we need to keep an eye on.
I'm sure there'll be many more questions. One very quick last one. Safety of lumbar puncture. That comes up so frequently. Who's safe to have a lumbar puncture with a Chiari and who not, if you don't mind?
Yeah, so I think the easy answer is no one with a Chiari, with a real Chiari should have a lumbar puncture. But I think in reality, it's those where there is no CSF space to allow that equilibration of pressure between the head and the spine. And that might be a difficult judgment. I showed that image where there was, you know, it's pretty clearly impacted, and that patient shouldn't have a lumbar puncture. But if it's for most Chiaris, it's probably safe. But the easy answer is to say no one.
We're going to have lots of interesting controversies. So this is wonderful. Thank you, Marcus. Thank you for that. Can I invite Professor Paolo Bolognesi to give his talk now, and then we can have questions, answers to continue. Thank you. Thanks, Marcus. Thank you, Paolo. Welcome.
Thank you. So thank you very much for having me as part of this panel. And, you know, I'm very honored and also a little bit nervous about following by two very eloquent colleagues. So I'm going to start with my talk, which is going to be a little bit more light and is going to look at more of a strategic perspective, especially because all the major points, clinical points, already been described. So first of all, a little bit of an introduction. I've been trained both in Europe and the United States, so I have a kind of a peculiar double vision about the socioeconomics of medicine, both sides of the pond. And I spent 20 years in a high volume Chiari center, and I was lucky enough to be partnered with two great names in the field. So I kind of sound already like one of those soldiers on May Day in the Red Square with a lot of medals, you know, kind of fatigued and worn out. I've seen a lot of patients in the office. Obviously, we were a quaternary Chiari center, done a lot of surgeries, and 40% of them were surgical revisions. And also I dealt personally with a lot of other pathologies which come as kind of a companion or ancillaries or partners in crime with the Chiari. So it's a very high number. You know, you make it up for yourself. It's not actually the highest number in the world for each and any one of these categories. Isiodos, interesting guy, not the happiest guy on the face of the earth back then. Back then, he wrote a book called Works and the Days. We still have it almost entirely. And he was mentioning about ages of humanity. Kind of remember from our classical education. And the golden age, actually literally was sounding something more racist that is not woke and would be canceled by cancel culture. But the golden age was an age of peace, harmony, and enlightenment, and everything was well. These benevolent creatures were preventing ills, and they're guardians of the mortals in a benevolent way. We're lucky to have a golden age in Chiari with a lot of giants which have preceded us. It's a long list, and these are the top of the top from different places, from different rounds of life in terms of discipline, mentality, and personality and surgical approach. What did they have in common? They occur in a kind of a restricted time. Before 1980, Chiari-1 malformation in terms of diagnosis, therapeutic approach was really the dark ages with very sketchy results and a very incomplete and very rough understanding. And during these 30 years, all these giants gave a massive contribution to the field. And is a plain number. They were having, since there were a few people, they had a high concentration of cases in a few centers. They had a full immersion approach to the problem. And by being surrounded by this all day in, day out, they start identifying patterns and concepts, and all this led to an enormous acceleration in the understanding and in the field, the strategic approach about how to approach it. approach the surgery and approach the problem. And this was an enormous difference clinically, culturally, and in terms of surgical results and care of the patient compared to what happened before 1980. So there were a lot of milestones which happened during these 30 years. Everything starting from Bernard Williams, and then it kept going. What I'm not going to stop on each and one of them. I want to give you the gist. There's a lot of advancement happened in this golden age. And the funny thing is that the rejection of 5mm rule among these giants of the field occurred in 1999. Until a few years ago, we still can go at meetings and hear people arguing, when in the mind of these people, this was already a clear-cut concept. These General Armstead and Gettysburg, they led the field and they showed to everybody, and they introduced many different things, including the concept of associated disorders. Now, Andy before he described very well the conundrum we have. We have hypermobility in some case, or we have instability in some case. What's the difference? And the difference is actually more logical that we can, once somebody gets lost in all the myriad of measurements, there are actually 14 measurements, morphometric measurements for the craniocervical junction. Everything boils down to something very, very simple. If you go for measurements alone, you can go to the Olympics, get the people on the national teams of our respective countries, and they're going to have measurements which are horrible. But you cannot tell them they're sick because they're doing things which are superhuman. On the other hand, you can actually find some patient with Ehlers-Danlos syndrome with measurements that are not particularly horrible, much better than the gymnast, and yet they are bedridden. In some cases, they're actually tetraplegic. So what's the difference between hypermobility and instability? Simple. Hypermobility plus a lot of symptoms, plus neurological signs is equal instability. So if you have somebody who's happy-go-lucky, moving the head in many different directions, who cares about the morphometrics? That guy is not unstable. So that automatically dismisses all the people who are going to come in your office with a lot of squiggly lines drawn on their respective pictures with suggestion of other colleague patients. And you're going to tell them, okay, so if you can move your head in any direction without symptoms, don't worry about it. Andy was talking in the beginning about the different mechanisms of tonsil herniation. One easy way to remember is push, pull, dangle, and squeeze. You can push from above, you can pull from below. It can be dangling because the tissue is like the cheek of a bulldog, or you can squeeze it outside of the skull because the skull is too small. One way to look at the most typical Chiari malformation is that it's a selective craniosynostosis of the posterior fossa, squeezing the brain out. So many other complexes have happened, concepts have been pulled out and pointed at by these giants over the course of those magical golden 30 years. And one strange episode is that one of the invention and the reinvention of the extradural technique. The extradural technique was actually first introduced in the late 90s by a group in New York. And that's the funny thing, you remember it's New York. And they used it for 3 years. And then when they started seeing the patients coming back for follow-up, they decided to abandon the technique because the failure rate was unacceptable. And what's unacceptable for one person or the other is kind of very subjective, but they were saying something like around 25 to 30% of failure rate. So that was not deemed as to be good enough. So they abandoned it. About 6 years later, again in New York, another group came up with the same concept of doing the extradural technique. And again, with the same observation that the SSCPs were improving during the removal of the skull only, and obviously was offering the advantage of not messing with the dura. This group from Colombia suggested, and championed the extradural technique in for many other pediatric neurosurgery centers in the United States, to the point that it didn't become the standard for pediatric neurosurgery in the States, but became a very, very strong movement. During the last 3 years, it is becoming more and more evident that the failure rate of extradural techniques is about 35%. So kind of history reinvents itself, especially when you don't pay attention. Yuri Gagarin, first man in space. Obviously, these guys were first in their efforts. They did different surgical approaches, surgical nuances. And one thing here that was not mentioned by my colleagues before, it happens more frequently than expected, especially when you do not go and check, and especially if you do not open the dura, is the imperforated velum medullaris, which can sabotage an otherwise anatomically looking good post decompression anatomy for a Chiari patient. Now, the concept of the surgical criteria was described by Marcus, and what are the surgical criteria? Several years ago, again in the late 90s, some of the giants we just said said, okay, you should not, if you're looking for, if the symptoms are the driving reason to bring a patient to the operating room, you should not operate for mild or moderate symptoms. You should operate for symptoms which are ruining the quality of life of the patient. So they were talking about different kind of scores. For example, Karnofsky score was 70. And then the second thing, they were saying, okay, if you have a syrinx connected secondary to a Chiari, you should operate on the syrinx if the syrinx is very large and the diameter is actually more important than the length. Or if the syrinx is blown up on one side of the center, or if the syrinx gives signs, especially neurological compromise. Or number three, if you have a patient that, regardless of Chiari or syringomyelia, has severe neurological deficit. So this is a menu which was presented in the late 90s. Now, with little tweaks, most of the experts are actually following, for the most part, these kind of guidelines. So these guidelines are old, and no one of the experts of the golden age would have ever operated on a patient with zero symptoms or minimal symptoms. Now, I was mentioning before the game on numbers. Once you start doing something over and over, like tying your shoes, you're going to get better over time, regardless of what you're, regardless. Obviously, if you have phenomenal dexterity, you're going to get there earlier, and then compared to somebody else with an average dexterity. But again, what Marcus was saying, those numbers reported on those tables from other colleagues, they're very respectable, they were unacceptably high in terms of pseudomeningocele. Pseudomeningocele being the fluid coming out of the dura but still within the soft tissue, and CSF leakage, the CSF coming out of the skin. Other people use the term of CSF fistula for that. CSF leak to be overarching for everything. But none of the experts that I mentioned before had any CSF leakage rate or pseudomeningocele rate, or however you want to call it, CSF, which is not contained in dura anymore, above single-digit percentage. So what is the magic number that we need before we are mastering a duroplastic closure? Somebody says 300, somebody says 200, 400, but for sure you cannot expect somebody to, with a limited neurosurgical experience, to write something that then is going to weigh in literature, as we're going to say later with the metadata, and then to be having the same weight of somebody with the enormous experience, like 1,000 and more, who's saying something otherwise. Something different in terms of opinions. Surgery, especially neurosurgery, is not a democracy. Two people with a minimal experience and with so complication, complication history, they don't carry more weight than somebody who has tripled their combined surgical experience and has a low complication rate. for people who do not know Russian, that Yuri Gagarin, the right underneath goes, glory to the party's son. Iron Age, going back to Hesiodus. Later on, after the Golden Age, Hesiodus was a big, fan of the past. He was looking himself around and he was saying, okay, things are definitely not golden anymore. There is hostility, there are infights, and there is a lot of chaos. What's the situation now? Lots of articles. There are actually many more scientific journals than we used to have 10 years ago. Lots of CVs which need to be buffed up in academia. And now all of a sudden you have a myriad of articles. There are actually more than 50 times the articles we had 20 years ago about Chiari-1 malformation. Pretty much mostly derivative, more than 95% of them. What I mean with derivative, things that they've been said, discussed, and already concluded back in the Golden Age, and now they're getting re-vomited in one package or the other. The problem is the metadata. If you have surgical series, for example, about extradural, intradural technique, or intradural technique with one patch versus another patch, you understand that articles coming from small centers with a very short experience, they create a lot of background noise that unfortunately weigh in on the metadata, which are again the recent vogue about scientific writing. The other problem about having this kind of democratization about Chiari surgery is that and there is nothing wrong about that, is that all of a sudden the experiences become fragmented. And the clinical and surgical experience of each and anyone who gets their feet wet with this, they become way more limited. And obviously kind of limits the ability of somebody to reach the understanding, levels of understanding, and the finesse of surgical techniques that these giants were doing back in the Golden Age. Now, there are also a lot of infights about clinical surgical opinions, and unfortunately, they're done by people with very small surgical series. And at that point, it becomes just it is like a fight about political parties, about Brexit against staying in, or Trump versus Biden. So it is not anymore a battle of the giants or a discussion among giants, but again, everything becomes very fragmented, and it creates a lot of confusion, much more confusion than it should be. Then there are other problems which are intrinsic to the way neurosurgery is becoming in modern times. The role of the residency is shifting. The residency programs are becoming longer. There are a lot of subdisciplines. The professors in academia have a lot of bureaucratic duties, and they have to spend a lot more time about taking care of their CV, again, because there has been a sort of a inflation about journals and number of articles. So all of a sudden, the residents are spending more time in the operating room than not their supervising professors. In the past, practically most of the people of the Golden Age, they were staying in the operating room from the beginning to the very end. Right now, many professors in academic institutions, they come in the middle of the case. Parallel surgery is a concept that has been proposed here in the United States and is taking off very quickly. Parallel surgery means that one professor of neurosurgery is covering between 3 and 4 surgical cases at the same time, that obviously are not operated by him, but they're operated by different residents, and this professor passes from one room to the other. Sometimes scrubbing in, sometimes supervising. Then there are a lot of advantages of progress that have brought a decreased sophistication in the residence product. So you have bioglue, and so they do a little bit of a fast closure, and they put the glue on top, and they keep the fingers crossed that that's going to create a watertight closure. Or now the extradural technique. Many people spend a lot of time not opening and closing the dura in the posterior fossa, which is not the same as opening and closing the dura in other parts of the brain. And then high tech kind of makes you a little bit lazy in terms of neural navigation, etc., versus the kind of thinking and approaching, kind of holistic approach that other forefathers had to have. There is nothing wrong with high tech, but it becomes a reason for laziness becomes a problem. So, and then there is also another issue, and I do not know how it's in Europe anymore because I'm missing from there since '92. But in the States, the original stress over craftsmanship and going slow, which was that one of Harvey Cushing, back from the 10s and 20s, from about 100 years ago, has been taken over by speed for a number of different socioeconomic reasons. So Bradley, we went from we're kind of slowly shifting from a Michelin 3-star restaurant to a McDonald's. To tell you also how things can decay over time, this is the Harvey Cushing at the Brigham, operating with his chief resident at the time. This is the last of chief residents, one of his favorite, Bronson Ray, who's opposite to Harvey Cushing with this headlight. So this is Harvey Cushing. This is last chief resident, Bronson Ray, who then became the chairman at Cornell. This is the last of the residents, the last chief resident of Bronson Ray. And this is the degenerate last resident of Dr. Mirat, who's myself. So as you see, things go downhill very fast. Now, another problem is you perceive what you see. So what is your personal concept of anatomical and clinical success? And if you ask that to different people, you're gonna see that what is acceptable for one is not acceptable for others. So we're missing what is a kind of a uniform set of anatomical and clinical goals for postoperative success. And how many times we hear, especially in tertiary quaternary center, the same story. Patient who went to Dr. XYZ, who gave his best surgical effort, then the patient goes back and he said, you know, like, I had the same headache as before. And the doctor says, you are cured, go to the neurologist. And the patient says, but this is the same headache I had before. I know now it's a migraine, it's not a Chiari headache anymore. So if you do not see if you want to see everything as success, obviously you're missing an opportunity for improving yourself. And then if you do not know where your suboptimal results in your complication go next, obviously you are having a overinflated perception of what yourself and your surgical technique or surgical technique you have chosen is doing. Very short story. Dr. Mirat was one of the main reviewers of the Red Journal, which is the Journal of Neurosurgery. And you know, all the articles for Chiari malformation were passing through his desk. One time he called me in his office and he showed me the draft, and the draft was coming from a very important institution, again, in the Eastern Seaboard of the United States, from big names. And they were presenting a case series of about 300 cases for 3 neurosurgeons. 300 cases back then was serious numbers. And they were showing that from their post follow-up analysis, which was kind of short, they were presenting a success rate north of 90%, so in excess of 90%. Again, 300 cases, 90% success rate, 90% plus. We look at each other in the face, and we had redone over the course of the last 5 years, 85 of those 300 cases. So obviously it was 95%, there was 90% success rate anymore if somebody has redone them. And so very diplomatically, he excused himself from the review of that article. So obviously you see what you see, and if you are not aware about what's really happened to your outcomes, you're going to have a skewed perception, to the point that it can become a self-fulfilling prophecy. If you're really, it becomes, you're convinced that something is working, and therefore unconsciously you're not seeing the elements that tell you otherwise. Now, I showed you my number before, and I had a unique opportunity. I was very lucky. And the more patients I've seen, the less black and white my perception about Chiari malformation became. And I developed more doubts about the entire thing, besides seeing it in a more granular version, not only for ERP, like I'm aware now what I had not understood 5 years ago. And that gives you a little bit of pause. But mostly, the greatest pause comes from the things that you hadn't found out yet, like all the story about the correlated or associated disorders like EDS that occurred. We're not seeing them. We're blind to them for the very first years of the existence of our center. So now, years later, we found other things. So you're always wondering, what am I ignorant about right now? What am I missing? One thing which really helped us a lot was to be, not to let the patients go. So whenever they were coming back with symptoms, we're clinging at them and using it as a kind of an opportunity to further understand. It is like the shepherd who cares the most about the sheep that is sick or the sheep that got lost, and kind of is lesser interested for everybody else that he is in the flock. Another lucky story that I had is that I operated a lot. And my first years, I operated a lot as a partner of Dr. Mirat, who was a taskmaster in OCD, to enormous degrees. Again, he was coming through the traditional. Harvey Cushing was super strong pathologic OCD. So I spent my first year and a half operating with him after my second residency. So I was an attending, I was working with him, and we're doing all the surgeries together. I spent 1 year and a half opening, closing, and opening the dura, but not being allowed to touching inside the dura. And at that point, and only at that point, I was allowed to do things inside. So, it was a little bit like Karate Kid, Ralph Macchio going wax in, wax off. Then I had the opportunity up that point to be strong enough to try all the Chiari techniques. We start with the extradural, then we push it up to the point that after my first 800 cases, I felt confidence enough to go and do different, more aggressive techniques like the tonsil resection in the mist, because at that point I was confident enough to be able to go up there without risking too much in terms of complications. And obviously, you never have zero complication. I would be really arrogant and wrong in saying that. But after a while, you become kind of a robot, and things become second nature. It's like playing basketball or playing cricket or playing football. Everything becomes like muscle memory after a while. One problem is that I see very well is medicine on both sides of the pond. I've been in the socialized European medical system, and I've been in the American one, which is capitalistic. And I've been inside, I fully understand the limitations and the advantages. Now, one of the perceptions that people from Europe have, looking at American neurosurgeons, say, "Oh my God, you guys get paid so much." Yeah, but there is a commercial reason for it. There is a very strong selection going in. When I came in the United States, I was already a neurosurgeon in Europe, and my chances to get in a neurosurgical program was less than 1.5%. The training is brutal. I spent 9 years, between 120 and 130 years of work every week. once you graduate, the competition is fierce, especially in major metropolitan area where most of the action is. And the Association of American Neurosurgeons regulates the market. So there is no big inflation. For example, in the Italian market, I know very well, there are actually more neurosurgeons graduating than what actually needed. The Neurosurgical Association in the United States regulates the market that there is a little bit less than the need. And that obviously drives higher salaries, but that's just a capitalistic mentality in action. Now, the mentality in the United States is very much workaholic. There are very strict contracts. There are a lot of incentives. The work hours are, they're brutal over here. To pull a 12 to 15 hour and go home and then do your notes and your emails is for us is a Tuesday. And all these factors in productivity mentality results in the accumulation as a concept. It's a very large surgical series. It's not that the patients fall in your lap, it kind of becomes a machine which reaches that as a byproduct. And here one of the things is that there are insurances also in Europe, but here the mostly of the system is insurance-based, and they're for-profit organizations. So they're not paying you. They're actually making any effort not to approve the patient and to pay as least as possible. So it's kind of a confrontation. And most of the bill that is given doesn't go to the surgeon or to the surgical practice, but actually goes to the hospital, which is the Medicare Part A. Then there is another concept which is called physician homeostasis. Every year, there is a deliberate effort of hospitals, whoever is your employer, to pay you a little bit less. So it is like somebody being in the pool and you do not know to swim and you go up like this on the tippy toes. Every year you do a little bit less, a little bit more in order to keep the same kind of pay. So without knowing it over 4 or 5 years, you should end up operating 40 more cases per year. Another problem is that the academic centers right now have indices and benchmarks which are actually driving the way you are judged, the way you are maintain your professorship, etc., and the way actually you keep your job. And recently, this number is also has been affected by the crisis of the elective surgeries. For example, with the advent of interventional neuroradiology, aneurysms went down, as well as the AVMs in neurosurgical places, done by neurosurgeons, done in the operating room. And the same is for some kind of tumors. So after a while, there was a hunt about what's the next pathology we can squeeze. And what in the past Chiari malformation, nobody wanted it. There were just a few people who were fanatic, who were getting them, and everybody was happy to give them up. Right now, most of the departments, they are hunting for Chiari malformation patients because right now there is no intervention radiology which can treat them, obviously the patients who are symptomatic. Another part which is makes easy for American centers to accumulate large centers is the fact that it's extremely cheap and easy for patients to travel. And patients with Chiari malformation are very militant and extremely networked. So they kind of find you even if you don't put the sign out of the door. Now, the byproduct of this is that being the proliferation of centers of excellence, some of them are true, some of them are almost true in the sense that they're going to get there, but as you see, there are a lot of reasons for that I described in the lines above for somebody to put the sign out of the door even when they're not completely ready yet. The social media and the internet is a kind of has been mentioned before. It can be a problem, can actually be a help, especially for the patients. The first approach, it sounds like something crazy. You have all these patients come to you and they look that they're part of a cult. They look like Scientology people. They have their own lingo And unfortunately, part of the lingo comes actually from our center. So I feel sorry about it, because we started doing patient education online back in 2002. So yeah, but for sure, many situations, these things have gone out of hand.
Paolo,
yes,
if you can hear me, I just wondered, this is very good. If we could try and accelerate to.
Yeah, this is the last thing. This is the last slide.
A lot of questions for you and
Yeah.
for the whole panel.
This is the last slide.
Thank you so much, Paolo. Thank you.
No problem. So at the beginning, these social media were internet-based. So there were people who were moderating, and they were kicking out of the door, out of the session, the crazy people. Unfortunately, now with platforms like Facebook and Twitter, there is no discipline, there is no moderation. So there is the crazy guys, the people who are less instructive but more have a louder voice, they go more, they are present more and more. And the people who are more moderate, they get pushed out. A lot of times these patients, they play doctor on each other, and they exchange emails or they exchange pictures, and they say, you have this, you have Chiari, even if there is no trace, or you have instability, etc. So they're playing doctors on each other. So that's absolutely a cons. And sometimes they go on, villagers with the pitchforks against one doctor or a center, because they're not bending to their, to their will. But there is also the positive part. The positive part is that properly channeled, like in the past, this thing can be a very valuable tool for patients to receive information, providing this with it out. So what is the message, the bottom line of this blur, blurting from my part? There were good things done in the past. We should remember those people of the golden age. They did just right. We should remember that they were not publishing every 5 minutes. They were publishing when they had something important to say, and they had large cases under their belt to support that observation. So we should just cut down a little bit on the background noise and to build up our experience, because from repetition, we're going to have a better understanding, and we're also going to have a far lesser, better surgical result and far lesser complication rate. So thank you very much.
Thank you very much, Paolo. That was covering a lot of the controversies, and thanks for the points. I just wondered if, for the sake of time and for productivity, if we can go to some questions and put the questions to the entire panel, really. Now, some of the stuff that's come up, really keen to, for example, address this particular question. The grades of Chiari are several, but we don't have a grading system. One Chiari malformation is not the same as another. We've already covered that radiologically there are various severities and there are different clinical presentations. And there's a range of neurosurgical options and managements. What do the panel think about having a grading system to help with classification of severity and guidance of treatment and assessing outcomes? Is this something that's doable, or is it something worth pursuing? Could I just ask maybe Paolo, maybe you first, and maybe Marcus and Andrew?
Marcus,
can I make a comment, Mansour?
Sure, please.
So, I mean, I think Andy quite nicely talked about Chiari 0.5, 1, 1.5. I think that's a mistake to think of Chiari as a grade like that. I think most of us who do a lot of Chiari surgeries know that it's actually the majority of patients who have descent of the fourth ventricle and the medulla below the foramen magnum, and so they're almost all 1.5 in that classification. So I don't think that's a useful grading scale. I just come back to the point that we don't really know what it is that's causing the clinical problems, apart from compression of the brainstem. I think that's pretty clear. The other things, I don't think we understand the structural or physiological basis for the problems. And until we know that, how can you grade it? Right? That's what we need to work on. We need to understand what are the underlying mechanisms, and then we can work out how severe they are.
Thank you. Andrew?
I suppose the difficulty, though, is if you're trying to treat people now, because what you're saying is absolutely right, Marcus, but how does it help people now with trying to work out what to do, how they're treating, who to treat, how to define it, how to talk to their colleagues about their patient that's got something, whatever this something is, Chiari something. Surely we've got to at least bite the bullet, don't we? And agree, or try and agree, or set out something that's a definition of a Chiari. And, you know, all these definitions are just going to keep coming. There's going to be a 1.25 and a 1.75, and there's going to be all these other things out there. I don't know. How do you think we can move forward with that?
Yeah, so for me, it's how far down does the tonsil go? I think is still a reasonable measure to look at. Is there deformation of the lower brainstem or upper cord? You know, that bump that you get when the tonsils really impact into it? The presence of that deformation, I think, is a really good sign that this is a significant Chiari malformation. And the absence of CSF space dorsal to the cerebellum, and in particular, if there's absence of CSF space around the whole foramen magnum, I think, and the presence of a syrinx, they're the things that are objective and that I think point to this being a significant Chiari malformation.
Okay, thank you. That's very clear. Paolo, any comments about that?
Yeah, in terms of classification, there's also a more general arch. The classification started with a pathologic criteria coming from autopsies. And they were actually they were putting in the same pot things which had nothing to do with each other. For example, Chiari-1 malformation is a disorder in the purest form, is disorder of the skull squeezing the brain out. So it's the bone affecting the nervous system. On the other end is the Chiari-2 malformation is a dysraphism. And so it's a disorder of the nervous system affecting the bone, especially for posterior fossa. So, and Chiari-3 and 4 had nothing to do with that. So it started with the pathological thing. Then in the 80s and 90s, when the MRI started becoming more diffuse and popular, especially starting in 85. And at that point, it became more of an anatomical / radiological classification. And recently, like especially what Andy and Marcus were saying, the pathophysiology is starting kicking in more. So other people, for example, were talking about we should not call it malformation anymore. We should call it anomaly, because malformation assumes that everybody should be sick, while the people who are sick in Chiari-1 malformation are just the tip of the iceberg. So I think that, you know, over and over, we're becoming more, among, you know, every time that the experts meet, we're always agreeing that we should change the terminology, and we should change the terminology, putting in a pair of glasses, which is exactly what Marcus and Andy were presenting before.
Thank you for that. Can I just ask the panelists, the conclusions which I've gleaned as someone who's listened to these presentations so far, some of the important points seems to be that Chiari-1 malformation is often a radiological finding, not a disease. And it affects about 1% of the population. Another is that it's a manifestation, it's an association with the condition. So as Andrew and Marcus have quite rightly pointed out, to look for the syrinx, to look for the hydrocephalus, to look for those cases where you suspect raised intracranial pressure, make sure there's no tethered cord or any craniocervical anomalies. During the investigations, do you think it's important to rule out any C1, C2 instability, and particularly addressing this opinion and cohort of patients which are presented and sometimes labeled as it is all Chiari, are related to C1, C2 instability? Surely there's a difference in the population that we see. So for example, when Professor Goel shows his results, which are wonderful, and the surgery is excellent, surely that's a different population subset, is it not, that have instability and the proposition of nature's airbag? Is that different to what you see in your everyday practice in your work?
Very much so. Yeah, very much so. We don't really see that as a major component. Of course, I think a tool shows some very convincing cases where that is the underlying pathology. But unfortunately, I think they've gone a bit far. And what they say is that C1, C2 instability is likely to be the cause of Chiari. Here are some examples. And now they've gone to say, but if you've got Chiari, that is evidence of C1, C2 instability, even if you can't demonstrate it with any other kind of imaging. And so it becomes a self-fulfilling prophecy, So I think that's just gone a bit too far. And so for us, we don't specifically look for it unless there are skull-based abnormalities.
We've done a series of imaging for quite a while on these patients, and I didn't find one with instability. So I've given that up. Now, a common question that's come up, and I know we want to do a webinar on this at a later date, which would be, I'm sure, a seminal one about operative techniques. But as so many people are asking, could I ask the panel, given the techniques that are around and have been done and still done, when you open the dura, I know some people leave it open, some people open in a Y, some people put a flap and stitch it to C2 and don't open the arachnoid. A lot of people do, and so on. But when you're going to do a graft and considering the results and the data, could you just comment on the benefits of putting a graft and what graft you use and the suture material you use for your graft? And this is the day and age of videos and operative videos, so we can really share that at a later date and really help make progress. But if you could discuss that a little bit, I'd be grateful.
And so maybe I'll answer this because I know Marcus and Paolo will both graft. Marcus, I was trained in the UK system of leaving the dura open, stitching it back. And Marcus convinced me at one of the meetings to change that. I then audited my patients compared to before I started doing it to after I started doing it. And it was just incredible because patients went home much quicker, they felt much better, and I had less revisions and less problems with CSF sort of shunts, hydrocephalus needed afterwards. So for me, I've moved very much to using occipital periosteum. I've tried Gore-Tex. I don't like it. It sticks. I had all sorts of problems with it. I tried bovine pericardium again. Didn't like it. Occipital periosteum, one, it's cheap. You don't have to pay anything else for it. And it seems to work very well. So I'll leave it to the guys who do much more of it than I do.
Yeah, go
I
ahead,
used
Mark.
to use Gore-Tex.
Go ahead, please. Paolo?
No, Marcus.
Okay, I used to use Gore-Tex until they stopped manufacturing the particular type of graft that I was using, and I switched to pericranium. And I wish I'd done that much earlier. It is much easier to work with. I started in using a proline suture. Preferably there's a hem seal type where the bore of the needle is much narrower. It's a little more finicky to deal with, but leaves very small holes in the tissue that you pass it through. And I've been very happy with that combination.
Thank you.
So
I sew it up under the microscope.
So we did a poll recently, and with the exception of one, all the people who had done more than 600 cases of Chiari decompression in their career, they all opened the dura and they closed the dura and they manipulated the tonsils. All the people who had done more than 100 cases, none excluded, they all opened the dura, closed the dura, and they shrunk the tonsils. So that should tell you something, that all the people with more experience, they are doing exactly the same. There is no debate on the top. About the autologous pericranium, I agree with Marcus. Been using for right now is 20 years. One of the advantages is that it's like it is a free graft, and if you have to go back in another time, like years later, like for example, do a craniocervical fusion, you find that piece of tissue has grown vessels inside. Is a living piece of tissue which has which is completely undistinguishable from the rest of the dura. And about material, I use something similar. I use Gore-Tex. The advantage of Gore-Tex is that the diameter of the needle and diameter of the thread is the same. The disadvantage is that it's a learning curve because the needle is very delicate. So you had to, everything is always in the wrist. If you are a little bit of the needle gets bent and then you create more problem. But once you pass that hump, it's the best stitch I ever used.
There's a saying that truthfulness is the foundation of all human virtue, and there's been a lot of talk about this truthfulness and different health systems. But coming back to this point about intervention, surely it's not that one size fits all. There must be some patients that we could say, well, I'll just do a bony decompression here and thin out the dura and make the slits and allow an expansion. What do you think of that as a proposition? And also, isn't it a bit concerning if we apply the same operation to everybody? And I'm not talking just about the pediatric population. So what do the panel think about that? Marcus, maybe you want to start?
Yeah, sorry, can you just repeat that?
So basically, when we hear that after a certain number of operations, someone does the same thing, this graft opens the dura, shrinks the tonsils and so on. We've all seen that and heard that in conferences. We know the huge experience from the group in Beijing. I've switched over myself to their technique largely, but I still do a variation with sometimes just leaving the dura intact and making slits and thinning it out. I just have difficulty trying to imagine there is one operation for everybody. So in terms of a Chiari, where there's craniosacral disproportion, tonsils are a bit tight, there's no syrinx, could it be acceptable just to do a bony decompression rather than a dura opening and grafting?
So can I throw it back to you and ask you, what is the technical goal?
The technical goal would be, for example, in a patient who has just got severe cough headaches, tussive headaches.
Yeah, what's the technical goal? What do you want to see on a scan afterwards?
An expansion of the posterior fossa and the CSF spaces.
Why?
Because that's associated with resolution of symptoms when I see
Is
them.
it? Is it?
From a certain proportion of patients that succeed with that. But what the advantage?
I'll throw that back at you, Mansour. I'm saying we don't know. I mean, we think we know. We think that create CSF flow and increase the space. But is that really what we're trying to do? And so rather than saying, do we slip the dura, open the dura, all of those things, we need to come back a step and say, what is the technical goal here? What is the actual structural thing that we're trying to address? And until we know that, all these other questions are, we're missing the mark.
So I agree. And this is for the whole panel. Please do feel free to chip in. But one of the questions just been put on is intraoperative ultrasonography. And I guess that's in relation to certainly in pediatric days when we used to put the ultrasound on and see just by opening the bone and getting a bony expansion, bony decompression, if there was adequate flow, and we'd call it the day. Now, yes, goals of the technique very important, but what we're all concerned about are the risks. The risk to patients, and this is an operation which has a mortality, a 1% mortality or less, and significant risks. Although I've personally not lost one from it, but this is a serious operation with stay on intensive care unit and so on. Is there a merit to considering a variation of the operation for certain patients who maybe not have a syrinx and are not very severe and are willing to come back for a redo operation if necessary to do a much lighter version? I put it to the panel. Sorry, Paolo, you had your hand up.
The first thing is, I believe in tailoring the operation and the nuances of the operation to the anatomy of the patient I have in front. Like nobody would go in the same place to get one suit with one size fits all. And obviously, the more experience you have, the more of a gist you get. The second thing is that, like variation on what Marcus was saying before. I am not stuck on one technique for another reason. Medical legally here, the patients are quote unquote empowered. So it's not like the old style, which is still in Japan. You go to the doctor and the doctor tell you, we're going to do this surgery and it's going to be like this, and you have no say. Here, the patient is not even called patient anymore. It's called a client. And you have to educate the patient, giving the tools to make the decision, and you have to give them alternatives. So part of this has led me to the deal of saying, okay, I'm a Chinese menu. I can do all the surgeries for Chiari, but generally what I do is like a variation on what Marcus was saying. The menu goes from here to here. I can do them all, but given what you have, for example, large ceilings or this or that particular anatomy, I'm just restricting your choice to this segment. And now I'm going to tell you the risk and benefits for all these alternatives, because going below that, I'm not going to do it because it doesn't make sense on the grounds of my experience. Last thing is, you were talking about BScan real time. There is a common misunderstanding between people put the ultrasound, they see the movement, and they say there is flow. That's BS. Color Doppler ultrasound is the only ultrasound technology which can measure flow intraoperatively. The only thing you're going to see with the regular ultrasound, with the BScan real time, you're going to see movement. And movement is not equivalent to flow. It is like if you see a patient, you open the skull of somebody who's brain dead, you're still going to find pulsatility. But if you check with an angiogram, the blood just goes like this, forth and back, but there is no net flow. So to see structures below the dura moving after the decompression does not mean there is flow. It simply means that you have a little bit more subarachnoid space or a little bit more pulsatility, but doesn't mean flow.
Thank you, Paolo. Thank you. That's a very useful point. Andrew?
I think my only point here is there's not one size fits all, is there? And you have to try and make up your mind by speaking to the patient and looking at the imaging as to what you are trying to achieve and think about how you're going to do that. And it's not one operation for anyone. You'll have certain techniques you'll do in one particular type, but you might do slightly different things for different people.
Thank you. There's a couple of questions about C1, C2 fixation and stability. I just wondered if the panel have some short, concise garment of brevity comment about the controversial point about hypermobility and hypermobility associated with Chiari. We increasingly see a large number of patients and patient groups with a range of symptoms who are thought to have a mild Chiari but have a disproportionate number of symptoms, and those who may have a hypermobility disorder associated with it. What do we do about such patients? I know
that actually is, first of all, is the selection. The patient who's hypermobile is going to flex, extend, rotate to the point that they can check their own back, like without symptoms. That patient is hypermobile. The patient who's actually unstable, he would rather get shot than moving because he's going to behave like somebody with a broken neck, because moving, the movement is going to get him in trouble. So that understanding and that selection can be done in a very simple fashion. That said, what to do surgically, first of all, you have to see if there is a surgical indication. The other thing is, if you have somebody with Chiari and there is an instability, craniocervical, which means base of the skull, C1 and C2, or C1 and C2, poses some problems of technical decisions. If you do a duroplasty and you do a fusion and you do them together, that's a problem, because if you do a fusion, you have to put the drain behind, leave a drain behind, and that is the kiss of death for the recent dural repair. On the other hand, if you do an extradural decompression, you in order to be successful, you have to remove a little bit more bone than you would do with other techniques, and that doesn't leave you so much of grasping space for the skull fusion.
Thank you, Paolo. I know Marcus and Andrew, all of us, we've got to come to a close soon, but I just wondered if I could, this last comments from Marcus and Andrew regarding the point about hypermobility and hypermobility association with Chiari. And I'm sure you get your range of patients. Any comments?
Well, first of all, for most patients, for the patients who present with typical Chiari features, even if they have EDS and have hypermobility, if cough-induced headache is the main problem, my approach is to do a posterior pulsar decompression. And most of those patients, in my experience, do well. And it's only a minority who have ongoing symptoms. And we have a pretty high threshold for considering a fusion, but we will have some patients go down that path. But it's a high threshold. I'd have to say the threshold is probably moving as we get more evidence and we see more of these patients, but we're cautious on it.
Thank you, Marcus. That's very concise. Andrew, last comments before we say good night, or good morning if in Australia, rather. Sorry.
So very quickly, I think some of the questions that have come up are slightly different. They talk about C1, C2 fixation and instability. And for me, that's not proven. And certainly I don't believe that's the cause of all the symptoms in every patient with a Chiari. And that's the only answer. I think it's a much broader issue than that. That might be contributing, and I'm not completely clear how much it does. I agree with Marcus. Certainly, when I looked at Millerat's data and when you talk to Paolo, the percentage of patients with hypermobility in his practice is much higher than what I see. Since I discovered this a number of years ago on speaking to Paolo, I've kept a lookout for every patient with hypermobility. As Marcus said at a meeting we were at 2 years ago, it came down in Niagara, it came down a consensus that most people agreed that if you had hypermobility in a Chiari and the Chiari was your symptoms, you dealt with the Chiari first and only then went on and talked about the hypermobility. In the UK, it's a big issue because a lot of patients they're not allowed to get their treatment on the NHS, and so they're going abroad for treatment. We've done a recent survey of these patients, and interestingly, a lot of them felt they were helped with surgery. A lot of them were having a large number of treatments. They were having C0 to T2 fixations. They were having decompressions at the same time, untetherings. They were having their jugular vein opened. They're having all sorts of things done. But overall, they seem to think that there was some benefit there. For me, it's an area that really needs a proper look at and more publications coming out of people with experience who can guide everybody else as to what to look for and what works and what doesn't.
I think that's very eloquently put, Andrew, on a very increasingly sensitive subject, because these patients do need help and they need our help, and we need to increase our knowledge base and the evidence. And may I take this opportunity to thank the whole panel and all those who attended. It's been a very long session, very grateful to everybody. Andrew, big thank you to you. Big thank you to Marcus, who's now going to work rather than us going to our beds. And big thank you to Paolo in New York as well. And also to Anna, who's been holding the fort as far as the ENS office. Thank you to everybody, and hope we can have another good webinar in the very near future. And we'll do one on the operative techniques, which I'm sure will be very popular and even more interesting. Thank you to everybody. Have a good night and a good morning to you, Marcus. Thank you.
Bye.
Bye. Thank you.